Welcome to the Wisconsin Health Transition Learning Community. This webinar is now being recorded, I think, unless there are objections. We're going to do introductions. During introductions, please give us your name, your organization, and if you're currently a shared plan of care grantee team. We're going to try to do this regionally. To start with, my name is Tim Markle. I'm over at the University of Wisconsin Wasteman Center, working with the Youth Health Transition Initiative. So I'd like to start to see if we have anybody from the Milwaukee area on our learning community today. Please introduce yourself and then feel free to mute your phone or your computer after you're done introducing yourself so that we don't have background noise on the presentation. Thank you. Milwaukee.
Hi, this is Megan Teed. I'm from the Complex Care Program at Children's in Milwaukee, and I am a shared plan of care grantee.
Hi, this is Meg Steinley with the Southeast Regional Center for Children and Youth with Special Health Care Needs.
Hi, this is Geeta Wadhwani with the Medical Home Initiative with the Children's Health Alliance of Wisconsin.
Hi, this is Amanda Slasher. I'm a social worker at Children's Hospital with Complex Care and Rehabilitation.
Any other Milwaukee folks on the call? Now let's move on to the greater Southeast area. Anybody from the Southeast area outside of Milwaukee?
My name is Susan Sandek. I'm with the Division of Oak Rehab.
Thank you. Could you repeat your name for me again, please?
Yep, Susan Sandek.
Thank you. Anybody else from the Southeast area? Let's move to the Northeast area, Appleton, the Great Fox Valley, Green Bay, et cetera, et cetera. Oh, we're missing the Northeast. Oh my goodness, how are we ever going to get along? Okay, let's move on to Northern. Anybody from the great north of Wisconsin? Or whatever we consider.
This is Allison with the Regional Center for Children and Youth with Special Health Care Needs.
Fantastic. And anybody from the western part of the state or northwest?
Hi, this is Dawn Kimple. I'm the Adult Disability Social Worker at Gunderson in La Crosse.
Fantastic. And anybody from Madison? And then we'll do Southern. So Madison area.
This is Dave Ballman from the Wisconsin Center for the Blind and Visually Impaired.
Great.
This is Becky Burns from CYSHCN.
This is Colleen Lane with the Medical Home Initiative with Children's Health Alliance of Wisconsin.
Naomi Kowald with the Medical Home Initiative and Children's Health Alliance of Wisconsin.
Ariana Kyle, also with Children's Health Alliance and DHS's Family Health Section.
Sharon Fleischresser from the Children and Youth with Special Health Care Needs program as well. Thanks.
Ann Harris at Witt Placement Center, Children and Youth with Special Needs program.
Peggy Helmquist, Children and Youth with Special Health Care Needs program. Something's going on here.
Anybody else who has anybody from the greater southern area then, non-Madison folks?
This is Betsy Roth-Wojcicki from the Medical College and Children's Hospital in the rheumatology section.
And anybody who hasn't had a chance to introduce themselves.
All right, Jacob. See you later.
Hi, Tim. This is Penny Funk from Marshfield Clinic Health System. I'm not sure what area I'm from, so.
Penny, you are welcome. You are among friends. And anybody else who would care to introduce themselves? I see Katie Erickson is here from ADRC of Brown County. Welcome, Katie. Judy Stike from Wisconsin Department of Youth Services is on the line. We may have a couple of microphones that aren't exactly working. Lynn Robick is also with us. So we do have a number of people on the call. I'm going to try to gather as much information as I can so that we can take a record of who's on the call. But I do want to remind you of a couple things before we get to the presentation. Number one, during the call, any background noise and conversations are not muted. On your line may become part of this archived presentation. They may also become very distracting for some folks that have trouble focusing. So if you are on the phone or if you're at your computer, please mute your microphone, mute your phone, and then when you would like to comment or have a question, unmute yourself at that point. This will help us in distraction and background noises. You can control this. You can control your mute in the Zoom conference room using the mute feature located in the lower left-hand corner of the window. For this call, we are looking for interactions, and we do welcome questions.
Yeah, it is.
And clarifications as we go through the slides. So when you want to talk, please unmute yourself. The presentation and accompanying materials will be available at a later date on the Health Transition website under the Learning Community tab. Hopefully you all received the agenda. Hopefully you can also see. Today we're going to be providing a summary and an opportunity for discussion around supported decision making. We plan to spend about 40 minutes to learn about supported decision making and then talk through some considerations for clinicians. Lynn Robick will be monitoring the chat box throughout the presentation. So if you'd rather type your questions into the Zoom chat box, that is fine. Any questions that we do not get to during the presentation will be part of the Q&A at the end. With that, I would like to introduce Tami Jackson, whom I had a great opportunity to get to know for the last couple of days. This has been fantastic. I enjoyed it.
Yep.
Tami's part of the team
wanted
that
you
drafted.
to be aware of what's showing up.
Tami has been a part of the team that drafted and helped pass the new supported decision-making law and is a public policy analyst and legislation liaison for the Wisconsin Board for People with Developmental Disabilities. Please try to mute your phone and mute your computers. I can only do so much from my end. Thank you very much. Where she works for the Board for People with Developmental Disabilities. She works on state and federal public policy to improve people with intellectual and developmental disabilities' lives and systems that serve them. We have a wonderful, very robust presentation.
Set up really good before
with that, we're going to go ahead and I'm going to go through and I'm going to try to meet everybody that I possibly can on my end. And then Tami, hopefully you will be able to proceed without interruptions. Thank you very much.
So Tim, I am not seeing the presentation on the screen. Oh, there it is. You read my mind. Perfect. And Tim, will you be advancing the slides? Or?
I will advance the slides. Just let me know when.
Okay. Okay.
Thanks, Tami.
All right. Well, with that, as Tim said, my name is Tami Jackson, and I have been kind of embedded in this particular piece of policy work for the last couple of years. Wisconsin is not unique in having a new supported decision-making law. There are now we're up over half a dozen states that have a law, and I am maybe a touch bit defiance, but I think Wisconsin's law is one of the best. Actually the best, and we can talk a little bit more about what that means. I understand from Tim that we have a lot of folks that work directly with children and families, so I'm going to try and talk about two things today. One is the concept of supported decision making, and then the second piece is what the law actually says, and then we'll talk about some practical examples of how this concept and supported decision-making agreements might be useful to practitioners in a healthcare setting. So Tim, if you could advance the next slide. Take a breath here. I'm just going to be talking about the concept here. Go ahead and advance the next slide, Tim. So it's really critical that folks understand that under Wisconsin law, Wisconsin law presumes competence. It presumes that everybody has the ability to make some kind of decisions and have autonomy over their lives. And since Wisconsin's law presumes competence, we probably should too. It kind of sounds like a simple statement, but working with the population that I do, I can tell you that oftentimes, especially if there is a visual indication that somebody has a disability, the spirit of the law is not necessarily followed. That when people see somebody with an intellectual or developmental disability, or even a physical disability, sometimes there's this assumption that presumes that they are not competent, and that in fact is out of keeping with what the law is. Supported decision making is really rooted in the idea that all people have the ability to make choices about their lives, and that everybody has the right to make choices. People can get help making choices without giving up their actual rights to make choices, and that people often need help in understanding, making, and communicating their choices. I am the mother of a just 2-year-old and a 8-month-old, and I am hoping that they will make different choices at different parts in their lives. And I always start this out by saying, all of us are growing beings, and we continue to learn and grow throughout our lifespan. So I think that when we're working with children and families, that's a really critical role that you can play to help those families see that their child's potential and growth, and kind of help facilitate high expectations that will help them live their most independent life possible. My 2-year-old is at the big saying things like "I decide" and trying to assert what he would like to do. He needs practice in making decisions and choices, and with practice I think he will make better decisions and choices, and I think that's probably true for all of us, no matter what our limitation is. Let's advance to the next slide. Supported decision-making it kind of sounds like this new foreign idea, but most families and people with disabilities and advocates are already using supported decision-making, even if they don't call it that. In fact, most people without disabilities are also already using supported decision-making. And when you think about some of the decisions, major and minor, that you may have made in, say, the last month or year, probably you didn't do that in an isolation bubble. You may have consulted somebody. It could have been a family member, or your husband, or a financial planner, or a realtor, or some other person that in your world to help you make certain kinds of decisions. Nobody made that decision for you, but you did probably ask folks for some sort of support in making those decisions. We choose people that we trust to help us gather and understand information, compare our options, and sometimes communicate those decisions to other people, but we are the ones making the decision. Nobody is making it for us, but we're using our wider network and our wider world to help inform us on the decisions we're making. And that is essentially what supported decision making is. It means helping a person gather information relevant to the decision they're making, helping them understand their options when they're making their own choices, and communicating that person's decisions to others. And that can look very different for each individual, but essentially that's the underlying premise. Tim, let's go to the next slide. When I was talking with Tim earlier this week, it seems like there's lots of folks that are really engaged with families and that are really interested in the idea of self-determination And I just threw this slide up here because supported decision-making is actually directly related to as a key part of self-determination. And there have been some research studies that quantify that folks who have a higher degree of self-determination are healthier, more independent, more well-adjusted, and in fact safer. So when you're thinking about like how do you encourage individuals to have greater self-determination, supported decision-making, I think, is a really important tool in that toolbox, and can really be helpful to facilitate greater control over one's own life. Let's go to the next slide. So this is a nice little graphic that kind of outlines some of the options for individuals that either want or need help with some or many decisions. And not all of them involve transferring their decision-making authority to someone else. For example, when you go the green column on your screen, release forms, there's you may be required to grant, for the individual to grant formal permission in order for someone else to see records, but signing a release form doesn't mean that the person loses their civil rights to make their own decisions. In the orange column, supported decision-making agreements allow the person to identify the kinds of decisions they want to support with, a supporter or supporters, and to define that role of the supporter without giving up any of their own decision-making authority. Representative payees and powers attorneys are a little bit farther down the continuum. They do grant decision-making authority to another person, and that can be for only certain decision areas or under certain circumstances. And generally that, it's a fairly narrow scope of authority. It's much narrower than, say, limited or full guardianship, which is on the purple column on the far side of your screen. Limited guardianship actually does transfer the authority to make some decisions to another person, a guardian. And in that case, the person is going through a court process. The court is determining that they are incompetent and assigning a guardian that's court appointed to act as a decider in some areas of their life. Full guardianship it's really a matter of degree. Limited guardianship, the person still retains their legal authority to make decisions in certain areas of their life. Under full guardianship, the guardian is really empowered to make many more different kinds of decisions. Supported decision-making, both the concept and the formal supported decision-making agreements can be used in combination with other legal arrangements, and that includes power of attorney and limited or full guardianship. These options are not mutually exclusive, and they can be used to complement each other. For a lot of people, supported decision-making agreements may be the only tool that they need to have. And for some others, this may be a part of what they are using. We hear, especially for those of you who are working with kids, I think we work a lot with parents as well. And some of the things that we hear about guardianship, most parents tell us that the first time they hear about guardianship is at schools, and it's always presented as you need to get guardianship by this time, almost framed as an administrative process. So we're finding as we do these presentations and just through our talking to people that most people are completely uninformed about what guardianship is and means for them. They're just kind of thrown into this process and told that they need to do it. The other piece that I think is alarming for folks is they don't quite realize what a guardian's role is. And we find that's also true for practitioners and people who provide services for people with disabilities, that when they hear the word guardian, they are also they also do not know what a guardian's real role is, and we hear all the time that there are guardians who are in fact probably not acting in either the best interest of their ward or sometimes in the spirit, keeping with the spirit of the law. So, you know, when it comes to working with families and kids, I think that this is a great opportunity as you're thinking about how are you engaging with families and preparing them for the transition to eventual adulthood, that using supported decision-making strategies, getting practice with decision-making, getting parents used to the idea that there will be a point where their son or daughter needs perhaps some privacy or one-on-one time with a physician, or will be making some decisions by themselves with regard to their care, is all extraordinarily valuable. Because what we hear from parents is some folks are entering into guardianship assuming that the relationship between a guardian and ward is the same as a parent and child, and that is absolutely not correct. And I think that the more parents can kind of get some practice with the idea of transitioning to adulthood and see that their child can be successful and has, you know, in decision making, and that this is a learning and growth process that will continue, the more comfortable they may, or less pressure they may feel to kind of make some permanent decisions when it comes to guardianship. Tim, let's go to the next slide. So I've covered some of this verbally in the previous slide, but I just want to make really clear for folks, and I actually am quoting our state statute on this, that the requirements for guardians under Wisconsin law are to make sure that, quote, the guardian is placing the least possible restriction on the individual's personal liberty and exercise of constitutional and statutory rights, and promotes the greatest possible integration of the individual into his community. That's role one. And the guardian also, under law, must make diligent, quote, make diligent efforts to identify and honor the individual's preferences with respect to choice of place of living, personal liberty and mobility, choice of associates, communication with others, personal privacy, and choices related to the sexual expression and procreation. In making a decision to act contrary to the individual's expressed wishes, the guardian shall take into account the individual's understanding of the nature and consequences of the decision, the level of risk involved, the value of opportunity for the individual to develop decision-making skills, and the needs of the individual for a wider experience. I think this is the language that's in our state statute, and it's really quite good. To me, it does communicate very clearly that the guardian is not the de facto decider, and that in fact the decisions that a guardian is making really have some parameters that err on the side of autonomy and independence. When I read that language, even for folks who are under full guardianship, supported decision making as a concept is a really valuable tool for a guardian to help understand their ward's wishes. It can be a very useful item to make sure that that spirit of what's on the books in the statute is really how guardians are behaving. Unfortunately, a lot of times what we hear from providers and physicians is when they hear the word guardian, they assume that that person has full authority to make all decisions for the person, and there's not a lot of knowledge of what the statute actually says. And there's oftentimes not even a check to see if somebody says that they're guardian, well, can I see your guardianship, letters of guardianship, to confirm that that person is in fact a guardian and what the limits of their authority are, because in this state and many others, you know, guardianship is not necessarily full guardianship. You may have a limited guardianship that actually grants the individual person their rights have never been taken away to make their own decisions in certain areas of their life. So I always like to remind folks that what the law actually says, because in practice, I think we hear things are working very differently. Let's go to the next slide, and this is just a break in our are dividing, so we can go to the next one. So this part of the presentation is really about what is Wisconsin's new supported decision-making law. The law passed last April. So this is a relatively recent development. We've had guardianship for, thousands of years. Obviously not in Wisconsin, we've only been a state 150 years, but that has been an approach that is familiar. Powers of attorney have been around for a long time, but supported decision-making agreements as a formal option are relatively new, not only in Wisconsin, but across the country. I think Texas was the first state that passed the supported decision-making agreement law, and that was, under 5 years ago. So this is definitely the next phase of supports, so to speak. Basically, supported decision-making agreements formalize, allow an individual to kind of define who they want to help them and in what ways. And with what decisions. So a supported decision-making agreement can be very narrow, or it could be a lot broader. You may have an individual who says, I really would like Bob to help me understand what my doctor is saying in a medical appointment. Fairly narrow role. It's Bob only in a certain scenario, and I only want him to help me understand stuff. Okay. Or perhaps this person could say, I want my supporter Bob to come to my medical appointments and have access to some of my medical records and to help explain to me what my doctor is saying and help me understand my options and help me communicate what I want to do to my physician. That's a much larger role. Both of those are completely controlled by the person under their supported decision-making agreement. And in no way does the person give up any of their decision-making authority to the support. It's also a good way for practitioners to understand that, a formal agreement allows you to know here's who's supposed to be here and what their role is. And that's a lot easier to figure out if somebody is overstepping that role. There's a clearly defined document about what does the person want. Let's go to the next slide. So the state statute actually does define who can use supported decision-making agreements. It's not just anyone. It's a subset of everyone. The law defines it as a person with a functional impairment. And that was deliberately, the definition is deliberately broad to cover, a broad set of people that we feel will benefit from these kinds of supports. So it includes folks with physical and developmental or mental conditions that substantially limit one or more of the individual's capacity for independent living, self-direction, self-care, mobility, communication, learning, or also referred to as major life activities. And it's meant to cover the populations of people with IDD, developmental disabilities, serious and persistent mental illness, physical disabilities. These are all folks that can use supported decision-making agreements. Other populations of people that can use supported decision-making agreements include people experiencing degenerative diseases or other like incapacities, and conditions that can be incurred at any age that substantially interfere with the person's ability to provide self-care. We deliberately did not define an age. We worked with aging advocates on this legislation as well. One of the things that makes Wisconsin's law unique, and in my opinion better than other states' approaches, is that it really does recognize the utility of supported decision-making agreements for many different kinds of people, including older adults. And of course, we were very conscious of, sometimes something can happen to somebody at 50 or 60 or 65 or 80 The age isn't really the defining factor. It's the functionality of when does a person really have an impairment that would perhaps warrant them wanting a supported decision-making agreement. So this covers older adults as well, even though there isn't an age, and we framed the definition deliberately broadly so that it recognizes conditions like early onset Alzheimer's or ALS or multiple sclerosis that really can occur at any age and have some impact on people's lives. The statute does not require the existence of a functional impairment to be determined or certified by a healthcare professional. So, you as the individual are assessing whether or not you have a functional impairment. This does not mean that healthcare providers have another layer of paperwork as people have to, as people say, hey, I need this to prove that I can do this agreement. We were deliberate about that as well. So I'm not going to read the slide to you because I think we've kind of covered some of these things, but the supported decision-making agreements, the scope of them is far broader than just healthcare. And that, again, is also deliberate on the part of the law. There are lots of decisions where a power of attorney really doesn't help you because most power of attorneys are either dealing with finances or healthcare, and many powers of attorney are narrowly constructed so that they are only activated under certain conditions. But the world of decision-making is bigger than healthcare and finances, and supported decision-making agreements can help fill in those gaps. They're also pretty flexible. So, a supported decision-making agreement, if a person needs more or less support in different or additional areas, you can just adjust that agreement to reflect that. And that is much harder to do with some of our current tools that are either focused primarily on one area of decision-making or there really isn't the flexibility to kind of adjust over time. One of the reasons why the law is constructed this way is that we know for research that especially people with IDD continue to gain experience throughout their lives, and then that can increase their decision-making skills. So these agreements can provide support as the person practices making decisions, and any changes in functional impairments, which could mean more impairments or fewer, through a rehabilitation process or progressive conditions, can change the kinds of decisions with which a person wants support. So it really is a way to kind of individualize and tailor the actual support that the person wants, and they are always in the driver's seat in deciding how they want their agreement to look. Let's go to the next slide. So this is really important, and I think we've been talking about this throughout the presentation. In supported decision-making agreements, the person's always in charge of their agreement. They are always the ultimate decider. Nothing about the supported decision-making agreement changes their civil rights or their authority to make their own decisions. And the person can listen to, can hear what the supporter is saying and then make a decision that the supporter perhaps personally does not feel is a good idea. They're always in control of their own decisions. Supported decision-making agreements don't give the supporters any new rights. The supporter has no authority to make the person's decisions. They can't sign legal documents for the person. They only have the authority and the role granted by the person under the conditions that the person has chosen in their supported decision-making agreement. And we'll get to those roles, I think, next slide. And let's go to the next slide. I was right. What's the role of the supporter? Really, the possible roles of the supporter are limited to the following 3 or 4 bullets. A supporter can help gather information, and it's not any information. It's information that's relevant to the decision that the person wants the support with. So in other words, if I have a supported decision-making agreement with Tim and I say I want Tim to help me gather information, that doesn't mean that Tim gets access to my Facebook account and can pull whatever he wants to know about. Tim gets access to the information that is relevant only to the decision area that he's helping me with. Supporters also can help people understand the information that they're gathering. So kind of thinking about it as a translator or an explainer role. That you have this information, help me understand what it means. They can help the person understand, whatever the options are with their decision. Including, if you choose option A, what does that mean in terms of responsibilities or potential consequences? But they have no role in saying to the person, option A is what you should do, and I'm going to tell you that I'm going to make that decision for you. And the fourth role is helping communicate the person's decisions to others. Tim, let's go to the next slide. Because we're dealing with a lot of folks that are in the healthcare field, never fear. Supported decision making. The legislation that was passed does, say, hey, HIPAA is still out there. If you're a supporter, you don't get to not have to comply with other regulations that might mean that you have to get permission from the person or sign a release to see that information. I think we already covered that the law really does limit access to personal information, and it also does require supporters to make sure that they're not, that they are not allowed to just release information about a person to anyone posting on Facebook. So I'm going to spend a little time now. Tim and I had a fun conversation on Tuesday about some of the different ways that that this might be useful in a healthcare setting. Let's go to the first slide. And I actually have some, these are all people that I know and who've had these experiences in the last year. So I thought I'd share just some of the experiences that I've heard about and kind of trying to apply that to how supported decision-making might be useful. I have a board member of mine has cerebral palsy, and it's significantly impacted him physically. Like, he does not have use of his hands. He's in a power chair. It's certainly impacted his ability to speak and do things like basic self-care. And his speech is generally slower and can be difficult to understand if you haven't heard him before. And he often talks to me, and this is a man who is now no longer a child. He's an adult and he's in his 30s. But he has described to us several times that because of his physical disability and his speech, that oftentimes medical professionals have assumed he has a guardian. And even when he's explained that he doesn't have a guardian, he hasn't been believed. At one point, he had to actually have medical staff call his mother so she could confirm he didn't have a guardian, and that they could actually interact with him about his own medical care. As a person with a disability, I think his perspective is he feels strongly that being part of being treated as an adult is to not have to rely on his parents to intervene or be present in routine life events, and that includes medical appointments. So how does this relate to supported decision-making agreements? In my board member's case, part of his challenge is really communication. And he has a number of people in his life that have known him a long time and kind of understand his speech. So he was excited about this law passing because that meant that someone who was used to how he speaks could potentially come with him to a medical appointment and make sure that his decisions and his questions were clearly understood by medical staff. And this is true not only with folks who have speech impediments, but I know a number of people who are perhaps nonverbal or communicate with using apps or other types of technology, this is the same type of relationship. It's not that the person isn't capable of making decisions, but they are communicating in a way that is non-traditional and may be difficult for a practitioner to kind of interpret. And supported decision-making agreement can kind of help take the guesswork out of that for medical professionals, and probably facilitate medical professionals being able to gain important information like description of symptoms and those types of things accurately, and keep their patient engaged in their actual treatment options. Let's go to the next slide. The other piece, it's useful not only for the patient to be able to communicate with their practitioner, but also the reverse. Does the practitioner have confidence that the patient is understanding? I think anybody who works in the medical field can understand that medical terms can sometimes be confusing, and that appointment times are short, and they keep getting shorter all the time, it seems. So when you have patients, especially folks with disabilities, they may be hearing complex terms or informations or options they need help understanding, just because they are inherently complex themselves. And, they may have their own filters, conditions, could be illnesses, could be mental health conditions, could be side effects or medication or pain or differences in cognitive processing due to disability. All of those things can be factors that make it a lot harder to understand what is trying to be communicated. Of course, with IDD populations, we often deal with people who take a longer time to process, or maybe need things explained in a different way to understand and comprehend what's being said. And I think we can't discount also that, sometimes what medical folks have to say is a little bit, it could be emotionally distressing or deeply impactful to the patient's lives. And that's also, another barrier when it comes to, how well is somebody hearing what the practitioner is saying and really understanding what their options are. Everyone has kind of a unique set of experiences and ways of relating to the world that influence how they understand and process information. And supporters have knowledge of the person that the practitioner may not have, including communication strategies and past experiences that may help facilitate understanding for the person about what's going on in the appointment. Let's go to the next slide. So this is another example that actually was just this week. I have a coworker who, she's in her early 40s and she uses a wheelchair. The particular diagnosis isn't important. It's spinal bifida, so it is a developmental disability. And it impacts her mobility, but it has nothing to do with her intelligence. This is a person who's had a master's degree. She works full time, has her entire life. She's independent. And she was telling me this week about that she met with a new primary care physician who took a look at her wheelchair, and the first interaction was to question her on who her guardian was. In other words, the first impression she has of the new patient is that her medical professional has assumed, based on her physical disability, that this patient cannot be who's deciding about their own care. Essentially, who do I need to talk to about you, and who makes decisions for you? The doctor also assumed, again, she's based on her disability, that my coworker was not married, which she is, and she assumed that she didn't have children, and she has two, because of the disability. So you set aside the impact these assumptions have on that doctor-patient relationship. It really also has an impact on that patient's care. If we're assuming that people with disabilities or kids with disabilities growing into adults, aren't going to be married, do we assume that there's never going to be sexual activity? Do we never assume that there may be other concerns unrelated to disability? Those are conversations that may not happen if you're not challenging those assumptions. Supported decision making helps, I think, remind folks that the patient is really the center of their care, and that there's definitely a message in supported decision making that even when a supporter is in the room, it's that support is only there because the patient has decided they should be, and the patient has defined a role for them in order to help the patient. And I think that's a powerful reframing from the example that I just described, where you are looked at and assumed that someone else must be in charge of your decisions. Let's go to the next slide. This one is a little closer to where some of your audience may be coming from. A lot of you may be working with families who are in what we call as transition age, that period of time where, from 17 to 21 is what we typically think of as transitioning from youth to adulthood. And I had a parent friend of mine recently describe an experience with her daughter, who is now 18. So this was a year ago. Her daughter has IDD. She has autism and is nonverbal and has another co-occurring genetic condition that I am not remembering. She uses an iPad to communicate. No problem with people who know her in understanding, but she's transitioning from youth to adulthood. And she's had an annual eye exam with a pediatric practitioner for many years. One of the challenges with her co-occurring disability is that it puts her at risk for glaucoma. So a routine eye exam is something that needs to be done. As you well know, specialists, their calendars fill up well in advance. So her mother made the appointment for her many months before she turned 18. And the day before the appointment, a nurse called her mother and informed her that she'd canceled her daughter's appointment because apparently the nurse had taken it upon herself to look up the patient's co-occurring condition, decided that diagnosis meant that she was not capable of making any decisions, and since she was over 18 and did not have a guardian, she couldn't have the appointment. Needless to say, it caused a lot of stress for the family, and they actually literally had to film on an iPhone, her daughter understanding the explanation of what she needed and doing her stamp. The practitioner intervened, she got her appointment, but I think it's another example of a real challenge, when we don't view folks as competent. Let's go to the next slide. And I have 3 slides left, and then we will take questions, if that's okay with folks. I think this is especially important for folks that are working with kids. I kind of said before, a lot of parents don't understand that the guardian-ward relationship is really not the same as a parent-child relationship. And I think that supported decision-making strategies are a good way to help parents practice this idea that, that children need time alone with their own doctor as well. Everybody, as they age, their bodies change and independently of their disability and health conditions. And, parents and practitioners really can't assume that kids with disabilities aren't going through the kind of normal emotional, physical, and sexual changes of adolescence. Like all patients, children with disabilities need some time alone with practitioners to discuss issues that they may not want their parents to be here or be involved in. And I think, that's an expectation when a lot of folks have become adults, and it should be something that is an expectation for kids too. And I think supported decision-making, at least as a concept with folks that are under 18, is a way to help facilitate that. Next slide, and then I think we're almost going to be done. This may not be as applicable to children, but sometimes a supported decision-making agreement is also a way to formalize a supporter's role if they're not like kind of that first direct kinship. Sometimes the closest relationships people have are with extended family, or their family isn't there, or they don't have family. There are lots of folks that have very robust social lives with disabilities where their most logical or trusted person for one decision area or many may not be somebody who's related to them. And a supported decision-making agreement is a formal way to recognize that role, you know, without people questioning whether, you know, your friend has the ability to be there. Next slide. We've kind of already covered this, and I just included this to remind us that supported decision-making is really useful throughout the lifespan. Certainly this, you know, I have a picture of an older adult here, and I was thinking about cognitive changes related to dementia and Alzheimer's, but this is also applicable to a lot of folks with disabilities. That idea that many people need a little help for a long time. This is a little help. It's not taking somebody's civil rights away permanently and giving them to another person, which is really the most extreme thing you can do in guardianship. With that, it looks like we're running out of time. I do have some other slides on more features of the law that you can look at when Tim sends stuff out later, but if there's questions, we can start chipping away at that. Oh, and there's questions on the chat. Okay. Let's see. The graphic that, the first question was about the graphic that kind of showed the range of support types. I don't have a link to that particular graphic, although I can send it to you. We have a number of products that Tim is going to send out after this presentation that BPDD has designed for families about supported decision-making and alternatives to guardianship, and a kind of streamlined version of that graphic is included in almost all of those. But if people want like a PDF of that graphic, I can certainly send it to you. We have one question about SDM agreements for education. Yes, SDM agreements can absolutely be used in educational settings. In fact, part of the law that was passed requires local school districts to make sure that they are talking about alternatives to guardianship, including supported decision-making, in their meetings with parents. I think there's a misconception that many parents are told that once your child turns 18, if you don't have a guardianship, then you can't attend an IEP meeting. That is absolutely not true. A student can always say, I want my parent to be in an IEP meeting, and part of the utility of SDM agreements, we think, is to kind of remind school districts that, yes, of course, if a student has turned 18, they can allow their parents to attend IEP meetings if they want, and here's a formal supported decision-making tool that says they want that. So we certainly see that there's some utility for local education agreements, and the same thing with you know, that we've been talking about here. Again, supported decision-making as a concept can be useful to teachers as folks are entering transition and practicing decision-making. Okay, that's the last question I see on my chat box.
So that'll end the chat box questions and the more formal part of the presentation. As soon as I can, I will get the PowerPoint made into a PDF and sent out to everybody on listserv and get it posted onto our website with Tami's permission, of course. We do have time for some questions concerning the presentation, but also we're very interested in knowing what other information about supported decision-making, guardianship, or tools to help assist in the transition of these children to adulthood using these tools, so that we can follow up with maybe a later webinar or get some stuff posted onto the website. So any questions or anything for further consideration that you would like to learn about?
I think Tim is going to be sending this stuff out to folks who attended this series, but we've developed an actual real toolkit, formal toolkit for families. And in that toolkit is a specific simple piece on supported decision making, a multiple pager on on guardianship alternatives, a worksheet for families on, okay, how do I do a supported decision making agreement, frequently asked questions, the official form that DHS has, for the a supported decision making agreement, and then a tracking form on like, okay, who are my supporters and where have I left my agreement? And that is available not only online, but we are certainly making those print orders available if people would find that to be useful for families in their offices. I also included a link at the end of this presentation. The National NDRN, National Disability Rights Network, has just published a short 8-minute video on supported decision making and healthcare and medical treatment decisions, and I think that might be very useful to some of the folks who are interested in this topic. I think it's a good refresher.
Yep.
So Tim will send that out too.
We'll send that out on the resource sheet, along with the National Disability Rights Network also has a frequently asked questions for medical professionals concerning supported decision making. So the link to that will also be on the resource sheet. Any questions for Tami or for your fellow practitioners?
How are you promoting this for families? Oh, questions everywhere.
Yay. Go, Tami, go.
This is a new law, and we are doing as much as we can to, we have a standing page on our website. We do a lot of these presentations. It's not only us, Disability Rights Wisconsin and folks from the Guardianship Support Center are doing a tremendous amount of educational presentations to all sorts of audiences about this new law. We found that a lot of families are seeking out supported decision-making agreements, and because they did not want the tool between no rights and no protections. So we found that there's been an overwhelming support for this new law, and people are running into institutions that either aren't familiar with it or are so used to, well, you have a disability, so you must have guardianship, that it's the parents on the front lines that are really sitting there going, hey, you guys need to honor, this new thing. I have a question about should or could a supporter ever have a conversation with a healthcare provider when the patient is not in the room? I think I can foresee a scenario where perhaps a supporter has been given the role of gathering information, and that may mean interacting with administrative personnel or other people to gain that information. So I can see that might be a scenario where the person isn't necessarily right there with the supporter, and the supporter is fulfilling their role. Clearly, if the supporter's role is to help communicate that person's decisions to others, or to help them understand their options, or kind of understand information, that to me implies that they are probably with the person while those, hearing the conversation, and that the person is somehow engaged, whether that be in person or maybe somebody's on the phone or, telehealth, it appears, however that needs to happen, it would assume that somebody is with them. Let's see here, any more? Medical decisions such as vaccine or routine screening tests. Can patients make appointments without their supported SDR? You mean supported supporter, maybe? Supporter being present? Well, remember, the patient is always in control. They're the decider. So if they're making an appointment for themselves, for medical stuff for themselves, they can do that. The supporter is not the, in any way the decider. If the question is about, can the supporter make an appointment on the person's behalf, I think the answer is yes, if that's what the supported decision-making agreement is requesting that person to do. That falls within, I'm communicating with somebody for the purpose of making an appointment. Think about the nonverbal person who wants to make an appointment, and maybe the easiest way to do that is a phone call. Well, that may not help you if you're nonverbal. So I think I answered two different questions, but I hope that was helpful.
Well, we are out of time. And Tami, I just really want to thank you for taking the time to the work that you're doing with supported decision-making agreements, but also for taking the time to put it into a clinical lens, because I really do appreciate that. If you do have suggestions for follow-ups, please let us know at the Youth Health Transition Initiative. We do have the evaluation form link posted. We will attempt to send that out to everybody that I can identify that was here today, which is a lot more people that were registered. So thank you so much for that. Please complete the evaluation link. Our next call is Thursday, September 26th. We'll be joined by Melissa Novotny from the Pediatric Complex Care Program, Pediatric Cerebral Palsy Clinic at the American Family Children's Hospital. We'll be discussing supporting self-management in children and adolescents with complex chronic conditions. So I hope you can join us again on September 26th. Thank you all very much.
Thank you.